Hey everyone, I'm in the studio today and we were going to be recording something, but there was some technical difficulties on my compatriot um, with her microphone. So I decided I would just hop on and do some of the other recordings that we have planned. And the first one really comes off of a community program we did here in Indian Harbor Beach at the Gleason Park Rec Center, which we looked at, why cholesterol doesn't tell the whole story for heart disease, and how do you actually really figure out your risk. Um, for those of you who don't know me, I'm Dr. Rebecca Hunton. I'm the medical director of Radiantly Healthy MD. I think you probably know me if you're watching this on our Facebook or YouTube channels, but I thought maybe I would introduce in case it gets shared. I was told I should have done that last time. So what's wrong with just standard cholesterol testing, and why is that all that you usually see coming from your doctor's office? And it is our community standard or proxy for care for heart risk. However, it misses 50% of people who actually are at high risk of having events, including my father. I'll talk about that a little bit further down. And we all know people. I mean, think about people in your community or family that have a cardiac event, a heart attack, stroke, something, but their cholesterol's always been normal. Or maybe they have one despite the fact that they're on medication. Or how about the person that has cholesterol over 300 and lives to be a very old age without really having an event? Harvard actually is following a huge cohort of these in the northeastern United States. I don't think it's just Harvard. I think it's a multi-center study where they're looking for genetics, like why does not cholesterol matter for some people? Um, so what does really matter? And it's what we call atherogenic lipoprotein burden. So not every particle that is in our blood has the ability to create plaque. And having plaque doesn't mean it's going to rupture or cause a cardiac event. We really need to be looking at things like how much inflammation's there, and how many of the particles we have versus the cholesterol. So there's genetics in there, and of course age. Any cardiac risk factor calculator you might see on social media or even just going to the American Heart Association, age and whether or not you're male or female biologically brings the highest risk. I mean, that factors most into the equation. There are other genetic risk factors. We'll talk a little bit about those too. So have you seen those ads on social media where it says, have this test done at 30 and it predicts your cardiovascular risk for your whole life? One of those is lipoprotein little a, and in fact, I think that's what most of those ads are targeting to sell to people or test for lipoprotein little a. LP little a is a genetic factor. It's a very small, very inflammatory, very atherogenic, that's a hard word to say, but it means plaque-making particle. You either inherit it or you don't, or you get one gene from mom and one gene from dad. And right now, we don't have really strategies or medications that work tremendously well on these. There's some being developed in the pipeline. Some of our conventional drugs that we use for cardiovascular disease, Repatha being one, has some studies showing that it does have benefit with lipoprotein little a. And so most of conventional medicine isn't looking for it. If you have it and like we find it and send somebody to cardiology, they'll say, oh, well, then we need to, maximize or I guess minimize or mitigate your other risk factors, since we can't do much about this one. And we do have some cardiologists in the community who are much more aware and open to prescribing things like Repatha. But Lp(a) predicts a little bit more than just heart disease. It also predicts where something is going on in the valve, especially the aorta coming off of the heart. So anybody who has the genetics for lipoprotein(a) really should have our echocardiogram done to assess the aorta. There is a specialist, or there used to be, people move around, but I believe he's still there, at Mayo Clinic, Jacksonville, who specializes in LP-LA and the issues with the aortic and the aortic valve that come off of it. If I go to a conference of lipidologists, I put them all together, and I'm like, what predicts heart disease the most? Who's going to have a heart attack right now? They don't draw a cholesterol panel. They're really going to be looking at something called myeloperoxidase, but even more importantly, usually the LPPLA2. Those are lab determinants that show actual inflammation in the heart vessels that could cause a heart attack to happen. So let's take a step back. I tell patients, plaque isn't really like under the sink in the pipe that gets built up. Plaque really is in the wall of the pipe. And if you remember being a teenager and getting those big angry zits on your face, the plaque, when an actual cardiac event happens, that plaque gets very red, angry, and then it pops. And when it pops, it recruits platelets and all the clotting cascade, and it cuts off blood flow, and that blood flow can usually, if it's a heart attack, it's in the coronary arteries, and that causes a heart attack. And I'm getting messages from the team. They didn't realize I was going to do this live. I'm fine with it being live. I just had to record it anyway, so why not go live? Anyways, so we're going to look for those inflammatory. If I want to know who's going to have a heart attack or who is at risk of having one right now, those inflammatory markers are the things we're going to look at. If I want to pick only one vial of blood that tells me the best predictor of 5-year risk, again, it's not the standard cholesterol panel, it's apolipoprotein B. B is in beta, and that is a lab test that's not very expensive, even if self-pay to do, and it's much more predictive because every single arthrogenic particle has an ApoB there. And so, and all the lifestyle factors, I think all the lifestyle factors that have something to do with running or cardiovascular exercise or how we eat and things like that, most of them will impact apolipoprotein B. So it really is a better predictor. Drink. Sorry. We also want to fractionate the lipoproteins, and specifically we want to look for the different types of LDL. And it turns out that the conventional cholesterol panel doesn't tell you very much about whether you got small, tiny, more aggressive atherogenic LDL particles or big fluffy ones. So when we fractionate it, we're able to figure that out. And of course, the LDL particle number and the LDL particle number size is much more predictive of atherogenic burden, plaque, risk of cardiovascular disease than just your standard cholesterol panel. We used to test this. In fact, when I first started doing this and teaching this, we used to test this and tell people, oh, you're lucky, you're an A, you inherited the big fluffy LDLs and you're not going to be at much risk. Or, oh, you are unlucky and you inherited the Bs. Whoops, I should take the ring off because I keep hitting it. And that's much more risky. So the LDL A's and B's, there is a genetic component. However, you can take somebody who's an A, and if they get sweet enough and become diabetic, that A can convert and become a B. And the person who's a B can, with lifestyle factors, move that a little bit further back towards the A. And that's now we follow the peak between A and B, as well as whether or not you have inherited an A or a B. And is it really inherited? Kind of. You know, we all know people who can get away with a lot, and we know people who can't get away with much. Their health shows up. A lot of times they're married to each other, and I think that goes back to the Middle Ages. I like to say Jack Sprat could eat no fat and his wife could eat no lean, right? You know, so it goes back in time where we have different things we bring to the table. So looking at this risk of whether I'm an A or a B and whether I make lots of particles or not so much. There is a little bit of genetics in there, unfortunately. Um, Back to talking about blood sugar and insulin, turns out that if you have prediabetes, insulin resistance diabetes, you have the same risk of having a heart attack as somebody who's already had one, right? And that's because insulin is incredibly inflammatory to the inside of the blood vessels. And so we always look and measure insulin, and fasting insulin, if you fasted long enough, may not be that high. We like to look at an insulin resistance panel, but also we like to look at insulin after you eat. Now, you don't have to eat like crazy, but we want to see how high is it showing up on a regular basis, because that drives cardiovascular risk as well. Homocysteine is another marker of inflammation that we draw, and it usually shows up on cardiac panels, even though it impacts way more than that. That's a whole nother talk about MTHFR and homocysteine and folate and B12, and that'll be another time. But homocysteine, when it's elevated, you're at higher risk of getting a clot, and it predicts endothelial dysfunction. TMAO is a gut microbiome, I love this, derived marker linked to causing heart disease and clot formation. Remember, the bacteria and that microbiome that lives in us eats what we eat. And so if I'm eating the standard American diet that's more inflammatory, I'm going to boost those types of bacteria and microbiome critters who like to make this stuff. So it's kind of a backwards way of how am I doing with eating. We also look at C-reactive protein. I think most of you guys know about that. It's a marker of inflammation. It's not specific to heart, but any type of inflammation like that can cause that. Genetic and structural risk factors, the coronary calcium score, we have ordered that in the practice for 20 years, and it's now in a favor to a place where a lot of people's insurance will cover it. The good news is, without insurance, with a doctor's order, I don't think they let you just walk in and do it. It's about $100 to get it done, and with AI and computer stuff, they can actually give you a little burst of dye and be able to figure out whether or not you even have soft plaque or obstructive plaque versus just quantifying how much plaque you have. So I think I've hit on almost everything that I talked about at the center, and we have come up with a heart panel that allows people to just get these things drawn without necessarily having diagnosis codes. So this is a self-pay panel that people can get drawn. There'll be more information about that in the website, and we'll put it on social media when it's ready. We've been working with a couple labs to try and get the best prices for these kinds of things. But here's my recording of the talk, or a summary of the talk, of the reason cholesterol doesn't really tell the whole story, and a lot of people are deceived. They feel like they're fine because their cholesterol's fine, or they feel like they're fine because they're taking cholesterol medication and their cholesterol's fine, and you really don't know until you do all this other stuff. Have a great day, and thanks for listening. End stream.